All right, so let's make a start. So hello, everybody. Thank you so much once again for coming to this chronic kidney disease webinar as a long-term condition for the Tier 2 cohort. My name is Yasmina, and I will be managing, facilitating this webinar. I would like to allow the educators to present themselves. We have Doctors Abir, Dr. Danya, Dr. Fidana. We have Senior Health and Wellbeing Coach, Jiga here, and we have Manpreet, our pharmacist. Would you like to introduce yourselves?
Yeah, so hi, my name is Abir. I'm one of the GP educators in Barking, in Central Dagenham PCN. I'm currently based at Talasi Medical Centre.
Hi. I'm GP at the Ilford Medical Centre and the PCN, Loxford PCN Education Lead. Lovely to see everyone here today.
Hi, I'm Danya Shoaib. I'm one of the presenters and the educators today. I am fellow PCN educational lead and do various educational roles. I'd like to introduce my lovely colleague, Dr. Sandeep Singh, who is now actually my colleague, being my trainee. So I'll just hand over to him.
Hi, I'm Sandeep. I'm still a registrar with a month left till I finish. Currently at Willis Medical Practice. Looking forward to doing this session on CKD.
Wonderful. Thank you so much. Right. Shall we make a
Manpreet?
start?
Manpreet?
Oh, so I'm so sorry. I'm so sorry. Go on.
Hi, I'm Manpreet Saini. I'm the GP practice pharmacist at the Willows Medical Practice, working alongside Dr. Danya Shoaib and Dr. Sandeep Singh.
All right. So could I please ask everybody to please mute themselves unless they are the speaker? Thank you very much. Let's make a start.
Okay. I do apologize. Sorry, I think that so today's session is going to be largely about what is CKD. Apologies. I think on the aim side we've missed off a few of the objectives.
Oh, sorry.
No, that's not your fault.
No.
I think it was just oversight on our side. So we will be covering obviously what is CKD, why is CKD so important. We have a section in the middle about the management of CKD, and then what are we doing to improve early detection of CKD. A few other bits about CKD versus AKI, which we'll cover in the middle. So I do apologize. The aim slide hasn't been updated. If we get the next slide. So what is CKD? Obviously, CKD stands for chronic kidney disease. It's a definition of a reduction in renal function or structural damage that are, or both, that are present for more than 3 months. And this is an important thing to bear in mind, that the classification does have a time period within it, because in theory, anything less than 3 months or reversible would be classified under the context of an AKI, so an acute kidney injury, as opposed to CKD. CKD, obviously, after 3 months, it's a chronic condition, and it's in real terms, once it's a result of the loss of nephrons within the kidney, and once those nephrons have been lost, they're not necessarily going to regenerate, though you do get minor fluctuations on blood test parameters, which can affect, which can reflect either an AKI, some dehydration, and things like this. It's a common condition, and it can range from, very, very mild, where the patients may have no or few symptoms, to a very serious and debilitating condition in which patients may require, renal transplants or renal replacement therapy. It's generally a condition which has an element of age linked to it. So, the older you are, the general assumption would be is that, the lesser kidney function you're going to have left, and therefore you're going to have a higher risk of having CKD. And it's also a progressive condition. So, obviously, where we've got that spectrum of mild and severe, you could start off mild and then progress towards severe, which is why it's important that we manage it appropriately throughout the patient's lifespan, to make sure that we minimize the amount of risk that they face in the long term. Okay, we move on to the next slide. So how do we diagnose CKD? So, obviously, we mentioned that there has to be the parameter of time, so 3 months. So we have to have blood tests, or it doesn't necessarily have to be the EGFR, but tests that are done which are separated in time. So ideally 2 GFR readings done more than 3 months apart, both suggesting that the GFR was less than 60, or you've got the GFR of less than 60 with the presence of microalbuminuria. So when we're testing urine ACR, or like an ultrasound scan diagnosis of something like polycystic kidney disease, so structural changes within the kidney. Okay, and that's generally about the formal diagnostic process. Move on to the next slide. And then we talk about the classification of CKD. So I may have mentioned a few terms, and apologies if I've not explained them fully. I would have dropped something like eGFR in there, which is obviously your estimated glomerular filtration rate. It's the rate at which the kidneys are essentially filtering the blood. That's the primary function of the kidneys, is to obviously remove toxins and impurities from within the bloodstream, and excrete them from the body via the production of urine. Now we use the eGFR, and it's largely being used as a classification scheme that you can see along the kind of the columns along the side, just like G1, G2, G3A, G3B, G4, and G5. And these are exclusively kind of differentiated based on the patient's eGFR, which we'll get back when we use in these for patients. And that's the traditional method that we used to use for giving people a CKD classification, the 3A, 3B, 4, or stage 5, which is like kidney failure. Now we have modified that, so we now incorporate the second parameter that we use, which was the presence of protein within urine. So we now map the patients into categories A1, A2, A3 based on the amount of protein that might be present within the urine. Okay, so you can see that traditionally, patients would have followed the amber structure down, like the green, yellow, amber, red. So 90, we would never have normally checked the ACR, so they would have just been like more than 90, so there's no cause for concern. But now, actually, even if they're more than 90, but there's presence of a significant protein in the urine, then they could still be a cause for concern. And I'm not going to spend too much time in terms of how we manage each of these categories, but just be aware that when we're mapping people in terms of the CKD classification, we should now use a G score and an A score, and the combination referenced onto the chart will then influence how we manage these patients. And one of my colleagues will talk a little bit further about how we would manage the different groups of patients based on the kind of color classification scheme that we have. I'm now going to, next slide, I believe I should be handing over to Dania.
Thank you very much, everybody. So why is CKD important? So basically, it's to understand the progression of kidney disease. Just like my colleague mentioned, it's usually with aging we see a reduction in kidney function, but there are lots of contributing factors to it. And what happens when if we don't stop it, stop things from progressing, where there's leading to kidney damage and then reduced kidney function. If you go on to the next slide, please. Thank you. So just why is it so important? It's basically the progressive nature of chronic kidney disease leads to end-stage renal failure requiring replacement therapy via dialysis. If the kidney stops working as the way it should, there is an increased risk of patients having risk of a heart attack, strokes, and other cardiac events. Next slide, please. So again, just carrying on. It's basically what happens if patients who have had the increased risk, they go through all these procedures, which in the end leads to a significant effect on their heart. And sorry, my slides have stopped. Can everybody see? So again, there is increased retention, which leads to increased blood pressure, high blood pressure then affects the kidneys, which again then starts deterioration of the kidney function. Next slide, please. So again, a slight repetition. If somebody progresses to end-stage kidney disease or chronic kidney disease, they end up having dialysis, risk of cardiac events, risk of strokes, and most of all of these things run in parallel. So it's really, really important to identify and treat earlier on, which my colleague will talk about in the management section. Next slide, please. So very, very important to observe and look at the common things that we see. We see as healthcare professionals while we're picking up the phone, talking to somebody, somebody coming in and giving us a sample to say, yeah, my urine has changed it's becoming more frothy and everything. Important to use our bedside techniques, important to test the urine, just go to the basics, using the normal stuff that comes up on our systems, using indicators, going through ACR checks and things, wherever is indicated is very important. Next slide, please. So if you keep pressing, Yasmin, I think, yeah. So again, people with chronic kidney disease end up having, if they come in and they present with peripheral edema, if they come up with significant cardiovascular risk factors, or we've just got to look out for those signs and symptoms and alter the management accordingly. What has caused this to happen and why has the kidney stopped working? Again, we're going to just address it a bit later on. So my colleagues here, one of the most common thing that presents to us in primary care is somebody having a telephone consult with somebody who has known CKD and is just very, very tired. So we do need to make sure that their kidney functions fine. There isn't something that's made their kidney condition worse. What are the common things? We need to start thinking and start looking and thinking back at the algorithm which Dr. Sheikh showed earlier on, looking at the mapping things accordingly and thinking how we're going to proceed with management once we've identified the possible risk factors. Next slide, please. Again, my colleague Manpreet here might be able to help me on this one, but basically CKD is very, very important. Why is the kidney so important? The kidneys are very, very important because they filter out all the toxins, all the medications from our body. It affects, if the kidney is not functioning properly, the whole metabolism of the body is affected. The way we function is affected. Next slide, please. So complications. What are the complications when the kidney doesn't work properly? As shown in the pictures previously, the patient might just present to you over a telephone call, which we might be taking remotely, is that we're tired, our legs are swelling up. How do we start thinking? How do we start thinking to make sure that is this the normal for the patient, or is our patient getting more unwell? What is it? What do we start to think about? Is there a salt imbalance? Are they retaining water? Do we need to think about doing blood tests? Is there a chance that their potassium might be increased? Are they on any medications that might have caused their kidney function to deteriorate? If you press next, please. And the most important thing that some of us forget is that chronic kidney disease leads to anemia, which does make patients very, very tired and predisposes like a vicious circle that pushes patients towards being from one stage to another. I'll hand over to my colleague for management. Yeah, I think Dr. Singh.
Yeah.
Yeah.
Hi everyone. So it's CKD management is huge. There's lots of parameters. You've seen all the complications. There's going to be a lot to discuss and break through, but I'm going to try my best to skim through most of it and give a nice review. So if we go to the next slide. So Yasmin, if you just click along the way. So essentially the key areas that we're going to focus on is going to be blood pressure control, glycemic control, and a combination of both of them. It's proteinuria. And the next one. We're going to focus on anemia treatment, going to focus on discussions about how we're going to prevent atherosclerosis in this cohort because they're at high risk, and also about something that people may know just term as vitamin D deficiency, but it's actually known as bone mineral disease. So if you click next. And then, so these are essentially what we're going to cover. I'm going to try and break it all down and cover each point that we're going to try and tackle in CKD. So let's start with blood pressure. If you click next slide, please. So blood pressure, essentially, if you click next a few times, thank you very much. So essentially there's two spectrums of it. There's either there's a diabetic, there's a non-diabetic, and with a enlarged proteinuria load. So you can see there I've written urinary ACR of more than 70, and then you have a non-diabetic with a lower urinary protein load. So these are the three categories that we normally tackle. So diabetics are essentially quite easy. And the reason I've not put urinary ACR, because I think the category that NICE involves starting treatment predominantly in hypertensives in this group, it's very low. It's 3. So I usually don't even include it in my management. If there's a diabetic that's got blood pressure, I start them on ramipril or losartan. The blood pressure targets are different. So if you have got marked protein in your urine, your blood pressure target it's at 130/80, which is the same as if you're a diabetic. Now, if you've got a lower protein load and you're not diabetic, so on the right side you can see less than 30, you've got a bit more space to move with your blood pressure, and that's 140/90. In these cohort of patients, you can manage it as normal hypertension. You don't need to give them ramipril and think it's renal protective. If they got CKD, they're not got much proteinuria, you can give them amlodipine and do normal hypertensive guidance, because what we want to prevent is renal microvascular damage. If you click next. So this is just an idea of what you want to do in someone that's got CKD. You really want to start with low doses. So with ramipril, you give 1.25 milligrams. You give it for a week. We give it for 2 weeks. Review it again. If the blood pressure is still high, add 2.5. After you reach 2.5 milligrams, there's no point going up by 1.25. Just go up by 2.5 milligrams, because you know that the kidneys aren't that sensitive and they're coping quite well. It's similar with losartan. The conversion is different compared to ramipril. So you can start at a higher dose, but if they're frail, consider a lower dose of 25 milligrams, unless they've got a very low EGFR. Next. So whenever you start patients on ramipril or losartan, some of you may have seen a drop in EGFR, some of you haven't. If you do see it, if it's up to about 20%, 25%, repeat it after a week or two and see if the results sustain. If it is sustained, this is what you actually do. So if you've got patients that have got raised a decline in EGFR, when you've up-titrated, for example, ramipril, go back to the tolerated dose they were previously on, and then repeat the blood test after a week. If patients have a constant decline in EGFR, despite the fact that you've gone back to the maximum tolerated dose, that'll be the time you want to talk to renal team, because we're trying to protect them from the proteinuria aspect, which causes a marked number of complication, which is the hallmark of CKD. And at the same time, you don't want to further decline the kidney function. Click next. So, and a few other points to note is sometimes these patients may have hyperkalemia. If you see them having a raised hyperkalemia, make sure it's not hemolysis. If it's not hemolysis and it's persistently raised, you want to hold off the ramipril and do an ANG to nephrology, because it may be a case that they might want to consider giving them a potassium binder while continuing ACE inhibitors because of its renal protective effects. So next slide, please. So I'm going to try my very best not to make this a diabetic talk. It's going to be a bit difficult because I'm going to talk through some of the agents. So we want really good control, really good glycemic control in CKD. The reason being because one of the parameters is it commonly being caused by diabetes. So if they've got a very low EGFR, you want to start reducing the metformin. And we all hear about this lactic acidosis. Metformin doesn't actually cause the lactic acidosis. It actually declines the renal's ability to remove that lactic acid. And that's why you have that. And then the next one is gliptins. So gliptins are actually quite safe to use in CKD, especially linagliptin, because it's excreted through your bile. But if you're using other gliptins, use it at a lower dosage. People most commonly, I think diabetic teams usually think that sitagliptin works better than linagliptin, but there's been no trials to date that suggest this. Next. So glycosides are very good. We use it commonly as rescue medicines, especially if someone's diabetic. If they've got CKD and they've got a very low EGFR, there's not much guidance on it. But if you've got EGFRs around 20, start with very, very low doses and monitor it. The problem with glycoside, once it's metabolized, its metabolites are very active. They rest in your renal urinary tract and they're not being passed on. They're not being excreted. So they're still active. And so you have a longer effect of hypoglycemia. So you want to make sure that you're safety netting them well and ensuring that they definitely are monitoring their BMs. And the other thing to say about this, they don't actually have any renal or cardiovascular benefit, very minimal cardiovascular benefit. There was a trial called Carolina trial that showed that there wasn't much effect that they had on preventing renal disease progression, but they do prevent the effects from diabetes worsening your kidneys. Next, please. And the reason I mention that is because we've got alternatives that are much better and that actually are renal protective. So GLP-1, I know we've limited this completely, but there are some GLP-1s that don't need to be any dose adjustments in low EGFRs. The benefits for the glutides is that it essentially reduces proteinuria. They don't prevent or reduce or improve the decline of your EGFR, which is a natural cause of CKD, but they do reduce the complications that come across with proteinuria. So if you click the next one, so this is essentially a summary of everything we've just discussed. The slides will be with you all, you can read through it. Now, there's one that I haven't mentioned yet, and I've given it extra slides because it's just an amazing medication that's been revolutionizing everything, and that's the SGLT2s, and that's on the next slide. The reason I'm emphasizing this is because it's finally been licensed for CKD and at low EGFRs. So if you click on the screen, you'll see that we've got a much lower parameter. We won't actually going, less than 15 is quite daring, but I think right now 20 is the limit that we are all reaching. And this is just a summary showing that when it's okay to use. Next, please. So here's a nice summary from the UK Kidney Association, who's implemented these guidelines. You've got a nice table there telling you when you can use it. If you click next, and again, and again. Thank you. So here you can see there's two main drugs that are here, dapagliflozin and empagliflozin. We hear it all the time. We have pharmacy reps coming to us. We can actually start using it at lower EGFRs. The current guidance from NICE is if you've got a low EGFR, even so you can see it's 25 for dapagliflozin and 20 for empagliflozin. If you've got a patient that's got CKD and is either diabetic, that completes the classification and indication for these gliflozins. The other indication is if they've got CKD and they've got a proteinuria of 22 or more. That fits in that criteria. Now, the key thing to know about gliflozins, less than 45 EGFR, your proximal convoluted tubules, they stop working with the reabsorption property. So you're not really going to have much with the glycemic control of diabetes. The only benefit you're having is renal and cardioprotective. So if you're prescribing this for patients that have got an EGFR less than 45, write down in your notes on EMS or System 1 that it's been prescribed for renal and cardioprotective measures. It's an amazing drug to the point that a Lancet meta-analysis has shown that there's been a 40% reduction in renal disease progression after starting this medication. Next slide, please. So this is just a ballpark summary of everything that happens. You got poor diabetes control, you got poor glycemic control, you got poor blood pressure control, you get really bad proteinuria. So how do we prevent this? You do all the managements we've just discussed. So this is a nice chart from NICE. What they have included is some of the SGLT2s, which I think they may be updating soon. If you click next, please. Yes, brilliant. So here are the two categories of when you want to actually start an ACE inhibitor. We've already covered that and we focused that on the blood pressure section. It's the same here. If they got diabetes and they got a very minimal raised ACR, you start them on ACE inhibitors. And usually when they got a raised, quite markedly raised proteinuria and a non-diabetic, you want to start them on an ACE for renal protection. Click next, please. And again. So here you can see where you would want to use some of the gliflozins. You've got it in the diabetic patients that you normally would start straight away with. And you've got some that are not diabetics, just have CKD, and they've got that protein leak, which is around 22 or more. Next slide, please. So anemia management in CKD. First, we need to actually know what the definition is. So if you click next, and again. So essentially, NICE sets this out as how we define anemia due to CKD. We want to make sure that if the eGFR is above 30, look for other causes. If it's less than 30, it's more than definite going to be due to CKD. So how do we manage it? First things first, you want to replace iron. Make sure they're not iron deficient. They've got a criteria where you want to make sure that the iron's at least more than 100. So click next, please. And again. And again. Thank you. So first thing is, so someone's anemic and they've got CKD, we're going to treat them with iron, make sure they're iron replete. If they're iron replete and they're still persistently anemic, or they've got symptoms of anemia, feeling very lethargic, having palpitation, and they're feeling short of breath, but there's no other cause found, that fits them for criteria for referral for EPO therapy, and we refer to nephrology for this. The advice from NICE is if someone's stage 3, we want to get a annual blood test done for them. If they're stage 4 or 5, we want to at least measure them twice a year. If they're in dialysis, there's no need because they get regular blood tests done. Next slide, please. Okay, next, click. So mineral bone disease, it fits this criteria. You've got abnormalities of vitamin D because the active component 125 is not working very well. You start to have sort of mismatch in the feedback system with parathyroid hormone. So your calcium phosphate don't work well. Your reabsorption of calcium in the gut is not going well, and in the kidneys. And normally, NICE is when we start monitoring these blood tests, usually when the CKD stage 4 and 5, that's when the onset of these conditions happen. Next, please. So this is essentially the overview of the 125 dihydroxy vitamin D that I was talking about, which is the main component that is activated by the kidneys from all the vitamin D we get from the sunlight or what we get from diet. Next. So what do we do if someone's got stage 4 or 5 CKD and we measure it and it comes back that they've got vitamin D deficiency? If they've got low vitamin D deficiency, there's some local pathway guidelines. This is from North Central London. There's advice on giving weekly treatment of cholecalciferol. If you've corrected the vitamin D and it's normal on blood results and they're still having persistent pain, that would be the time that you want to refer to nephrology because they can start a bit more stronger medications for vitamin D replacements that will require a bit more monitoring and potential shared care management. Next, please. So if you've got the other spectrum, you've got CKD patients, and now all of a sudden you're seeing that there's changes in the calcium and phosphate, start thinking there's something happening with the feedback system. Are they developing secondary or tertiary hyperparathyroidism? Do they test the the PTH, parathyroid hormone, see what's going on? If they've got persistent hyperphosphatemia just due to the fact that the kidneys are not filtering it really well, then what you want to do is refer them to nephrology, because what ends up happening is that the nephrology team will then do an MDT with a renal dietitian who will start them on low phosphate diets, do a review, and if it's continuing, then they'll need to be on phosphate binders, specifically calcium acetate, being an example. Next, please. So statins. So if you click next, and again, and again. So this is just a quick summary of statins and antiplatelets and their role in CKD. So there is secondary prevention that we do offer in primary prevention. We start at a low dose of statins. Now, a lot of the time that patients tend to be on these because they already have coexisting comorbidities. So they might have angina, they might have had a previous heart attack, they might have peripheral arterial disease, or they've had a stroke in the past. So commonly they'll be on statins. But likewise for antiplatelets, that these patients, usually it's for secondary prevention. And secondary prevention means they've already got a cardiovascular risk factor. The primary prevention for statins is essentially they're at high risk of cardiovascular disease. So when you've got someone that's got CKD, you would give them only give them anti-lipid therapy if they've got raised cholesterol. However, if they've got cardiovascular risk factors, or they've had a stroke, or they've had, an ACS episode before, it doesn't matter what the lipid levels are. You will still give them treatment, and that's in line with these conditions anyway. So there's not much focus on statin antiplatelets because a lot of the patients end up being on them generally anyway. Next, please. Okay, so I'm going to hand over to my colleague, Manpreet Sahni, to discuss the rest of the presentation. Thank you very much.
Thank you, Sandy. Okay, so when to refer, reasons when we might need to consider referring the patient to nephrology. Well, for a start, when we've already taken a look at the classifications of chronic kidney disease. So usually, if you get a patient who's in what is called stage 4 and stage 5, G4, G5, or if the estimated GFR is less than 30%, that's when you may well need to consider whether you need to have that discussion with a specialist service, the nephrologist, even if it's not a case of they need dialysis or anything others, but it might be a conversation to be had. It's a conversation to be had. Usually, the exceptions are, if, for example, if the patient is quite stable on CKD stage 4, stage 5, and if they're very ill or anything like this, you have to take a look at a patient in a holistic manner. So you have to use your own judgment as well. So if you do have somebody who's terminally ill, frail, it's probably inappropriate to speak to nephrologists or get any nephrology guidance. There's if anybody's ever come across this, there is a website which you can use for kidney failure risk equation, and usually this tends to work if your EGFR is 59 or less, and if the 5-year risk for needing renal replacement is greater than 5%, then that's another reason why you may well need to seek guidance from nephrologists. If by any chance you happen to find that there is a sustained decrease of EGFR, if it's 25% or more, and if there's been in the last 12 months, there's been a change in the EGFR category that we mentioned earlier, then, or if that's happening, or if the EGFR has decreased, if there's been an EGFR decrease of 15% or more in a year, then once again, that's rapid enough for you to consider a nephrology advice. Basically, the idea is to get the intervention in as early as possible so that we can at least slow the progress down. Usually when we start, we all probably know that when we start somebody on an ACE inhibitor or an ARB, usually we tend to say to them that within 2 weeks, please tend to have your blood tests done. Typically, what tends to happen is that the kidneys don't sort of tend to react to them within the first 2 weeks, but by the 2 weeks, they should have recovered. However, if the EGFR has fallen by 25% or more, or if you've noticed a 30% rise in creatinine, like from baseline level, during the first 2 weeks, then what you may well need to consider is stopping the drugs, repeating the tests once again, and if there's no other causes that you can find, such as the ones which are listed, such as volume depletion or NSAID use, even some of the thiazide, so diuretics, for example, or something like that, then go forward and you do seek specialist advice. And obviously, if you cannot find any obvious reasons for any deterioration in the kidney function, then once again, you will need to consider speaking to a specialist. If you can click forward, please. So this is just a snapshot of the website that I was mentioning, and this is basically how it would look. So it would actually give you some kind of an idea of what's going on and what's the projected deterioration in kidney disease. So if you can click forward again. Okay, and here's just a list of some other reasons why you would refer. For example, if for the very first time you come across somebody who happens to have a CKD or G3 level, obviously it comes as a surprise, especially if the patient is quite young. I know I've certainly seen some. So once again, you may well need to consider a referral. Usually, if it's something like, if it's quite mild, but then there's a genetic diagnosis or something like that, then usually referral. Unless those things are happening, then usually referral would help. But otherwise, usually G1 and G2, we don't worry about them too much. It's usually 60 seems to be that cutoff point. If by any chance you get isolated proteinuria, whereby the urinary ACR is over 70, or the PCR is over 100, or those levels are a bit more tighter, if you happen to get any microscopic hematuria, then once again you may need to consider referral. usually, I mean, there's other things obviously that you would need to think about, because obviously if you were to get things like blood in your urine, once again, you may want to do a 2-week wait referral to urology just to exclude things like bladder cancer, for example. If the patient is over 45 and they've got visible hematuria, but there's no, the dipstick is negative, or the MCS show that there's no infection of any kind, once again, you may need to consider that. Or if it's a persistent urinary tract infection that a patient tends to get, because obviously things like that can affect the kidneys as well, then once again, you would need to consider your referral there as well. Say that patients over 60 years of age with one or more hematuria, or they have dysuria, then or if they have raised white cell counts or FBCs, then once again do that referral. Some of the investigations that you need to consider, well, if you were to test the EGFR, these are some of the things that we tend to do in primary care anyway. Testing for EGFR, doing the urinary ACRs, which at this point in time, let's face it, most of us are going a bit crazy doing that in primary care. But that's one of the things as well. And also patient and doing a blood pressure check in patients who have hematuria as well. If anemia, that's another cause as well. We just mentioned it, Dr. Daniel Shoaib mentioned it earlier, that when you, anemia is a big part of it. So if you were to find a patient who has a hemoglobin which is less than 100, or if they just happen to be symptomatic, is something that we need to think about. It's basically think kidneys. And if they happen to be on 3 agents and they're still uncontrolled, their blood pressure is still uncontrolled despite having 3 antihypertensive agents, then once again it's something that we need to consider as well. And also, if we think about it, I always describe to my patients that your kidneys are the one which sort out the chemistry of your blood. So if that chemistry, such as your calcium, your potassium, your phosphates, are out of range, once again, think kidneys. Can we click forward, please? And again. Okay, so some of the things that we need to think about now. If you've got, as we've mentioned, if you've got new marked lethargy, usually when we think of lethargy, somebody comes to us and complains about lethargy. One of the things we think about is anemia, of course. We think about diabetes. We think of their thyroid, but we need to once again think kidneys. If a patient has noticed that they're not passing as much urine, or that they're completely anuric, once again think kidneys. Other things which we might not think of is things like hyperventilation, confusion, chest pain. If you think about confusion, that's something which gets commonly seen in the elderly when they have a urinary tract infection. So once again, we're thinking about that kidney area as well. Uncontrolled malignant hypertension symptoms, and also things like facial edema, puffiness of the face, and that's actually seen more commonly than we think. We click forward. And some of the main causes, well, for a start, there's your acute kidney injury, or things like acidosis as well. When we think of acidosis, also we think about our diabetes patients as well, who tend to have things like CKD, things like that developing as well. So that's something to think about as well. If there's any obstruction or anything like that, that would require an admission to hospital. So you would need to send them to A&E for that. Things like pulmonary edema, if you find things like that, they can also have that adverse effect on your kidneys as well. And remember, you also get acute kidney injury on chronic kidney disease as well. So that's something to think about as well. And obviously, as you can see from the list as well, things like encephalopathy, pericarditis, any kind of electrolyte changes. Some of what I've seen myself as well, you would admit those to hospital as well. Thank you.
Next slide, please. Hi, so it's myself, Fazana, again. I'm going to be talking about improving the early detection of CKD and why it's important. Apologies, I'm just going to turn my camera off due to a tech issue, but hopefully you can hear me absolutely fine. So thank you, Sandeep and Manpreet, who've nicely gone through the medical management, and I'm going to be introducing also how we can involve the wider multidisciplinary team. As we know, CKD is increasingly common, and there's increasing recognition that early identification and management is critical in delaying progression. Estimates suggest that in England, about 3 million people have CKD, but many actually don't realise they have the condition because it has so few symptoms in the early stages. And about 1 in 1,000 people actually progress to needing dialysis or a renal transplant. And one interesting statistic I read earlier was that the economic burden of kidney disease itself on the NHS is about 7 billion, which is a massive figure actually. So being aware of who's at CKD or risk of CKD is valuable as it facilitates the screening of these people and also hopefully enables us as healthcare professionals to intervene with pharmacological and lifestyle measures to reduce these complications and the progression, as we've heard about earlier. You can see, not surprisingly, I've listed some of the groups of those people who should be screened, and they include people with risk factors for CKD, such as diabetes, hypertension. It says at least once in every 5 years, people with hypertension should have a renal check. People with a family history of renal problems, and those with structural problems affecting the urinary tract, including a history of renal stones. Additionally, people that we should formally screen for CKD include people that we incidentally find have a reduced renal function, so that's an EGFR of less than 60 mils per min, or proteinuria more than 3 milligrams per millimole, or those who we find on urine dipstick 2 out of 3 times that they have some persistent hematuria. Once we've excluded UTI as a possible cause. The screening process itself is relatively simple. A blood test looking at the kidney function in terms of EGFR, coupled with hopefully an early morning urine sample test to look at the albumin creatinine ratio. Next slide, please. So the key thing to be aware of is albuminuria, even with an EGFR within the normal range or above 60, can still be indicative of kidney disease. And that's because healthy kidneys stop the filtration of albumin into the urine. So the presence of any albuminuria is an indication of kidney disease. And you can see that on the graphic heat map that's featured earlier in the presentation. Columns with G1 and G2 still change to yellow and orange as you move on to A2 and A3. One point I would like to make here, which is quite key in early detection and screening, is once we do the screening, it can lead to diagnosis, but it's important to check the information is recorded onto the primary care record. On their website, the London Kidney Network makes the point that the CVD Prevent audit they did found approximately 34,000 adults with evidence of yellow and orange level of disease didn't have a formal diagnosis of CKD on their records. So they miss out on all that management, which we've heard about earlier. So that's people in G3A to G5. So I would say one of the key messages of the webinar today is whatever our role is, when we access a patient record, be sure coding is correct and up to date. Next slide, please. I think Sandeep and Manpreet have kindly gone through the triggers for referral, which is denoted red on this graphic, and they've also gone through the medical management, which makes up a lot of the actions needed during the monitor phase, which you can see in yellow and orange. Next slide. But I think one of the strengths of early detection is we can also start the process of empowering patients to play a more active role in managing their condition beyond being the recipients of prescribed medications. And this slide summarizes the nice guidance of steps needed for holistic management of patients once a confirmed diagnosis of CKD has been made. The left column summarizes the actions covered by Sandeep and Manpreet, ensuring comorbidities and risk of progression is medically managed. But the column on the right suggests addressing lifestyle factors associated with disease progression and also monitoring the mental health of patients who've been diagnosed with CKD. And this is where our colleagues in the wider multi-professional team, particularly personalised care roles, can help. And I'm going to hand over just after the next slide. If you can go to next slide. And next slide again. I'm going to hand over to G after I've talked through this slide, just to talk through how the personalised care roles, which include health and wellbeing coaches and social prescribers, can play a role in helping patients make lifestyle changes. The slide I've skipped over just really delineates the role for the clinical pharmacists, and Manpreet and Sandeep talked about that beautifully, about how medication and monitoring medication is helpful. But specifically mentioned in the guidance is things like stopping smoking. So smoking has been associated with severe proteinuria and progression of CKD, drinking alcohol moderately, maximum 14 units a week and over at least 3 days, keeping a healthy weight and taking regular exercise and eating a healthy diet. So managing these kind of cardiovascular risk factors is advocated by NICE because it reduces the risk of cardiovascular complications and CKD progression. And I think this really is where the personalised care roles come into their own in managing and helping these patients take control of their health and well-being. I'm going to pass over to Jeet, who will tell us a little bit more of how they can help.
Thank you, Farzana. Next slide, please. Hi, everyone. I'm G. I'm a senior health and wellbeing coach. I've been in this role for about 3 years with some operational leadership supporting primary care networks embed these roles. I'm also the personalised care MDT faculty lead for personalised care. Next slide. Really, I want to talk about how the personalised care roles can support patients, clinicians, and pharmacists manage long-term conditions. Now, bear in mind, we are non-clinical roles. I'm just going to talk you through roughly what the health and wellbeing coaches, social prescribers, and care coordinators can contribute to in person-centered care. So health and wellbeing coaches are really experts in behavior change, working in a person-centered way. We aren't directive or prescriptive. Actually, we focus on what matters to the patient and work with them to fulfill their wellbeing goals. So we set personalized goals and improve their well-being, increase their motivation or activation levels to see how committed they are to make changes to their lifestyle, and obviously advocate exercise and fitness regimes, generally signposting them to local community resources. Social prescribers will look at other aspects of the well-being, giving people time to focus on things like their housing situation, their social situation, financial situations, and really connecting them with community to support them meet these issues that they may be facing in their life, which may be contributing to the deterioration of their well-being. And care coordinators really walk alongside in a person-centered way and see the bigger picture. Some of the work they do, they support the vulnerable, the frail, or people with health inequalities to coordinate and navigate care across the healthcare system and reduce the stress and anxiety for those who have difficulty understanding what is happening to them or accessing services. Next slide, please. Just some of the feedback. We have had some real life cases. And again, just to be mindful that we do look at the 360 dimensions of well-being. So this is not the disease state in itself. So we're not looking at CKD specifically, but this could be any long-term condition in a preventative or early intervention way. So things like excellent service, reduce my anxiety. A lot of it's to do with mindset and behavior. Just giving patients time to talk through their story and help them change their narrative has a huge impact on their well-being, and also being able to give them the time to talk. So our sessions as a health and well-being coach, my sessions are usually 60 minutes long, and patients have up to 6 sessions to share their progress or issues related to their well-being. Next slide, please. Just to reiterate that we don't deal with disease-specific conditions per se. Really, we're looking at other factors that matter to the patient. Next slide, please. I'm just going to give you a brief overview of that. Some of the common presentations that most of the personalised care roles deal with are these, and I'd like to just put it out there to the audience. How many of you can actually relate to some of these signs and symptoms? Now, you'll be surprised that a lot of these signs and symptoms are really due to stress. Next slide, please. And a lot of the work that I do with patients is to help them understand what impact stress has on their well-being, understand their triggers, and empower them with self-management techniques. Isolation is a big one. So when we connect people with community, they actually feel supported because they don't feel alone in their disease state, or and also it helps them improve their well-being state. So with stress, I'm sure you're all familiar with the general adaptation syndrome, so I'm not going to really go into this much. But one thing to know is that the awareness of stress actually empowers individuals, and whether it's a small stressor or a big stressor, the body only responds in the same predictable way, meaning we can do something about it. Next slide, please. Now, some of the coping strategies Fazana's already touched on are smoking, caffeine, drinking, chocolate, which is just a sugar high. Next slide. All of these are stimulants. So if we're indulging in stimulants, how can this actually help us? Well, there's a neat trick to this. Next slide, please. It's not actually the coping mechanism. It's not actually the smoking or the caffeine that's helping us, that's actually contributing to more stress. It's actually the act of getting up out of our seat, walking either out to have a cigarette into the fresh air, or walking and to make a cup of tea and having a discussion with someone. So when we're feeling aspects of stress or pressure upon ourselves, it's really important to include a bit of movement, unplug from what we're doing, and get some fresh air. So here are some examples of what we would signpost patients to help them restore their equilibrium, which actually helps them to heal whatever condition they are in. So things like hydration. A lot of people will think caffeine is hydration. Actually, it's not. It's contributing to the stress. So really avoiding caffeine, sticking to herbal drinks or water. I've put some resources here which are very useful. Please feel free to check in on them. Next slide, please. Again, just press it one more time. One of the biggest things that we do as personalized care roles is really bring patients into the present moment awareness. And this is through things like the bellows breath and body scan, which really helps people come straight into their present moment. And that's when we can start changing the narrative. I think we're short of time, otherwise I'm going to run through bellows breath, but I shall leave it at that. Thank you.
Thank you so much, all of you. That was really wonderful. I'd like to open the floor on the chat, as it were, if you have any questions. Thank you, Danya and Sandeep. I know you were monitoring the message box. And I would also like to tell everybody, please, please, please take literally 30 seconds. I'm going to put a survey, questionnaire, multiple choice, where there are about 3 choices for each question, and there are basically 4 questions, including your name. So you don't even have to think about that one, just to say what you felt about this webinar, and you'll get a certificate of attendance if you answer it. Thank you so much.
Yes, I'd really like to emphasize that if you can just take 2 minutes and fill out the feedback form, it really helps us plan future sessions and how we would address any other further training needs that would come out from the group, especially as now we're moving towards multidisciplinary learning.
Yes, exactly. Okay, let me just get it on.
Hi, Joe. How are you?
Danielle, lovely to see you. I thoroughly enjoy that. I couldn't keep quiet. But I just wanted to comment really about the anemia in renal failure. As you know, I qualified in 1900 and frozen to death. And I was a renal registrar in 1979, 78. And when you came to outpatients, you could tell who did not have a transplant. They were all pale. So half the waiting room were in pallor. They were pale, they looked weak. Once they had a transplant and they were getting erythropoietin, which is manufactured in the kidney, you could see they sort of walked to the other side of the room. And EPO, the treatment for anemia in CKD in selected cases, as Sandeep pointed out, is revolutionized the treatment. So now people with CKD are not anemic, they don't look anemic. And it's just brought back memories of walking down that outpatients in Westminster and seeing the pale people who you knew were not transplanted. And you knew who could, just by walking through the room. And one of the professors used to ask the students, which one of these had transplant? And he'd ask me, and I would very cleverly point out all the pink ones. And he says, you know, that's why Joe's a renal registrar and you're not, that sort of thing. It was nice, but it's revolutionized really. And I've diagnosed a few people with CKD on a blood test with anemia. They came and they were feeling tired. You do a blood test, they have a very low EGFR and they had polycystic kidney disease, which they didn't know they had. So, you know, it's part of the workup. Obviously, someone's tired, you do a blood test for anemia, it goes without thinking. But thank you, just brought back happy memories of all those years ago.
That was very, very nice to hear. That's good for us to have a spot diagnosis now when we see someone coming in pallor.
Yeah, yeah.
Hello, everybody. I've put the link. It's great for those of you who have answered. Please, the others, I would urge you. We would love any comments you may have. Sorry. Any more questions? Thank you, G. You've given some information there in the chat. Thank you very much. All right, so I shall stop recording. For those of you who want to stay on just to be able to fill in the questionnaire, that's totally fine. Thank you ever so much. We hope to see you in the next webinars.